Okay, let's talk about bariatric surgery or weight loss surgery. So before we do all that, we got to talk about some definitions. So how do we determine if somebody is overweight or obese? It's based primarily on BMI. BMI, body mass index. So BMI is one of a few different ways that we can see how overweight somebody is. Is your weight in kilograms divided by your height in meters squared. A BMI of 18.5 to 25 is normal. 25 to 30 is overweight. 30 to 40 is obese. And greater than 40, we consider to be morbidly obese. So why do we call it morbid obesity? When you hit that BMI of 40, that's when all the coexisting medical problems, or what we call the comorbidities, increase in number. Actually, when you hit a BMI of about 32 to 35, depending on what country you're from, the rate of comorbidities goes up exponentially. So let's talk about those comorbidities. Obesity affects every body system from head to toe. So starting with your brain, about 30 to 40% of our patients with obesity have depression and or anxiety. Which came first, the obesity or the depression? Anxiety, who knows, but there's definitely a correlation. The majority of our patients have cardiovascular issues, things like high blood pressure, high cholesterol, cardiomyopathy, lung disease. At least half our patients with obesity have what's called sleep apnea, which is a fancy word for snoring, which interferes with your sleep cycle, GI issues, fatty liver. So fatty liver is now the #1 reason for liver transplant in the United States. It used to be hepatitis and alcohol. 80% of patients with obesity have fatty liver, which is not the end of the world. 15% go on to get NASH, which is inflammation of your liver, and then 3 to 5% get what's called fibrosis, which is scarring in the liver and the beginning of cirrhosis. Diabetes. 80% of people that are obese have diabetes. A quarter of people who are morbidly obese, regardless of any family history or any genetics, will go on to get diabetes. That's 3 times the risk of the normal average population. In addition to diabetes, there are 14 different cancers associated with obesity. So what's the common denominator? Cancer, diabetes, NASH, which is fatty liver. All these are caused by inflammation. Fat cells are inflammatory by nature. So all these medical issues that you're seeing is from an overproduction of inflammatory cytokines. Before we get to surgery or why you would need surgery, it's important to know that this is an epidemic. We're facing this epidemic, especially in the United States, because of our eating habits and our activity. So over time, #1, our portion sizes have gotten bigger. There's a lot more carbohydrates in the foods that we eat. #2, we've become more sedentary. Big screen TVs with all these apps where people just sit at home, watch TV. Our kids are sitting behind their iPads. We have so many different modes of transportation. People are a lot less active than they used to be. So because of this imbalance between calories in and calories out, we're facing an epidemic in which 40 to 50% of people in the United States today are obese. So why surgery? Unfortunately, when you get to a certain BMI, which is somewhere around 35 to 40, the odds of being able to lose weight and keep it off are very low. The odds of keeping it off at that BMI actually are probably about 5 to 10% long-term. Surgery, on the other hand, has about an 85 to 90% success rate at 5 years. So what does success mean? It means that you were able to lose 50% or more of your excess weight and keep it off at 5 years. So now, what are the different types of surgery? So the most common operation that we do around the world today is the sleeve gastrectomy. In the sleeve gastrectomy, we're basically tubularizing or creating a banana shape out of your stomach by taking out 70 to 80% of it. The reason this operation works, well, obviously there's a restrictive aspect to it, which means you can eat less. But most importantly, there's hormonal changes that occur in your body. Hormones that affect your appetite, your satiety, or feeling of fullness. So the sleeve gastrectomy alters your hormones in a positive way, which helps you to lose weight, but also keep it off long term. The issue with the sleeve gastrectomy, the Achilles heel of that operation, is reflux disease. So about 10 or 15% of patients will get new or worsening reflux in my hands. We do things to try to prevent that. A lot of our patients have hiatal hernias, which we fix at the same time as sleeve gastrectomy. I specialize in anti-reflux surgery as well. So any patient that has reflux after a sleeve, I'm able to help afterwards if needed. Typically, only about 1 or 2% of patients will need any type of revisional surgery after a sleeve for reflux disease. The second most common operation that we do across the world really is what's called a gastric bypass. The gastric bypass has been around since 1967, first discovered by Mason and Ito. We've been doing it laparoscopically since 1993. Any operation that we do for over 50 years, close to 60 years now, is a good operation. So the gastric bypass is a combination of restriction and malabsorption or decreased absorption. So the first part of the operation, we decrease the size of the stomach to about the size of a Coke can. The second part of the operation involves a bypass where we reroute the intestine. In addition to the restriction and the malabsorption, like the sleeve, there are many positive hormonal changes that are occurring with the bypass. So things like ghrelin, leptin, GLP-1, GIP, neuropeptide Y, all these hormones are changing and interacting in a positive way to make weight loss happen and to keep weight off long term. We do a lot of revisional surgery here. About half of the operation that we do here are revisional, primarily for other surgeons. If you've had a sleeve gastrectomy, you have trouble swallowing because your sleeve is twisted or it's too tight or you have reflux, we fix that. If you've had a gastric bypass that you're having issues from, we can fix that as well. We even do revisional surgery for patients who have regained a lot of their weight back or didn't lose enough weight to begin with. As far as our results, so I've been doing this for a pretty long time. I've done many hundreds of these operations, probably close to 1,000, and I've never had one single mortality, knock on wood, during this operation. Our complication rates are about 1/5 to 1/10 of the national average, especially amongst revisional surgeries. The success rate, as I mentioned, about 85 to 90% of patients lose the weight and keep their weight off at 5 years. As far as the workup goes, so every patient that we see has to come to one of our free seminars. Every patient has to meet with our dietitian and our psychologist, not to exclude you from surgery, but to optimize you for surgery beforehand. We get labs, a full set of labs, including vitamin levels in everybody, and everybody gets an endoscopy to see how things look on the inside before we do surgery. As far as vitamins go, on that note, you have to be on vitamins for the rest of your life. Even with a sleeve, more so with the gastric bypass. You may not notice issues with it early on, but it will catch up with you over time, especially after a gastric bypass. If you don't take your bariatric specific vitamins, you're at risk for developing vitamin D deficiency, B deficiencies, iron deficiency, and anemia, amongst others. Those reasons, in addition to many other reasons, we have a lot of follow-up with our patients. So we see our patients at 1 week, at 6 weeks, 12 weeks, which is 3 months, 6 months, 9 months, 1 year, and once a year after that. We check your labs twice in the first year, every 6 months, and then once a year after that. In addition to keeping you healthy, we want to keep you on track. Don't be ashamed, don't be sad or discouraged if you regain weight or don't lose the amount of weight that you want. I promise you we'll find a solution together, which is why we encourage so much follow-up. Last piece I want to talk about, the weight loss injections. I'm a believer in the weight loss injections. The weight loss injections have been around for about 6 years. It started with Ozempic and Wegovy, which are semaglutides, evolved into what's called Mounjaro and Zepbound, which is tirzepatide. I don't prescribe Ozempic or Wegovy because it has more side effects and it doesn't have the amount of weight loss that you see with Mounjaro. Mounjaro does not only work on GLP-1, it also works on GIP, so 2 different hormones. Because it's acting on 2 different hormones, you get a synergistic effect, you get more weight loss, and miraculously with less side effects. So in select patients who we think are appropriate candidates, we will do weight loss medications or injections for you. If you get above a certain BMI, usually around 40 or higher, the medications become less efficacious and less likely to get to a reasonable goal weight. So a lot of what we do today is a combination of surgery and weight loss injections. If you think of obesity like cancer, you have to target it in different ways, with surgery, with chemotherapy, with radiation. In the same way, we target obesity just like we do with cancer, with surgery, with medications, and with dietary behavior.